Okay, so we go ahead with the next presentation.
Dr. Nagendra Chauhan is doing it, sir. Vascular access site management and ideal patient site for a smooth muscle for a site vascular closure devices. So, Dr.
Hello.
Yeah, Dr. Kumar, how are you?
Yeah. Please go ahead.
And thank you, Dr. Shikumar and Dr. Farang, for inviting me for this nice meeting. So my presentation is mainly on vascular access site management and suture-mediated vascular closure devices. So as preventions for coronary arc can be done through radial access. So vascular access closure was initially not that important once radial came, but after structural intervention gaining speed, now it is very important, equally important for, I think, for coronary also and for structural also. So most important to recognize is that once you are going for femoral vascular access especially, then because of the newer technologies, now we are worried about tower and mitral valve and all those kind of things. And the basic thing is puncture, and generally it is underrepresented, and it is the major cause of complication. So most important thing is to assess the vessel size, and then you should know that what kind of intervention you are planning and for which what kind of sheet you have to use for devices to be inserted and what is the size of that sheet. So that's very important to assess that complications because of vascular access are the most common complications, like in tower. Partner B trial data was shown in even 2010. The maximum complications were happening because of vascular access, because we are going with the large bore devices. Initially, they were 22 French, 24 French. Now, with the advent of newer technology, now they have came down to 14 to 16 French, but still they are quite big for many small size patients, and that causes complications. So you have done the major procedure, but there was a major complication of femoral access, and that can be dangerous sometimes even for life. The small hematoma gradually developing overnight may cause severe hypotension, and patient can die because of that also. Definitely, intraperitoneal hematoma is a major complication, and generally we can prevent that. But even small hematomas because of minor bleed are dangerous, so we should prevent these complications. And to prevent this, the most important thing is that we have to select the right patient. So for patient selection, it's very simple that generally female patient, old age patients, patient with peripheral vascular disease and calcification are the patient in which complications are more common. If we are using a bigger size devices, then complications are more common. And definitely you need experience to use these devices and closure access sheets for closing the vascular access. So the simple rule is that your stiffness artery to the sheath ratio should not be more than 1.05. If it is more than that, chances of complications are much higher. Although in younger patients with smooth arteries like this one, you can go up to 1.1 ratio, but with patients with heavily calcified artery, you have to underestimate. You should not underestimate the complications, and the ratio should not be more than 0.9 or 0.95. The other important thing is you have to decide what kind of sheet you are using for the procedure. Like for tower, we are using a 14 French sheet commonly, which is expandable. 14 French sheets, internal diameter is 4.7, but generally external diameter is almost 5.3. So you should know that you need a 5.5 size vessel for that. So any vessel which is less than 5 is not a good idea for these things. And any vessel which is between 5 to 6 is borderline. You have to assess calcium and then decide. And more than 6, definitely you can go ahead and do it without any problem. So this is very important to understand that what kind of procedure you are planning and what kind of sheet is required for that. So most important is femoral access. So for all kind of advanced procedures, we are just simple imaging. So always go for a CT first, and on the basis of CT, decide what is the size required. Like in this patient, the femorals are reasonably good, but aorta, the level of aorta size is very small, just 3 millimeters. So this can be a good case for any kind of large access devices like tower or any other procedure. Another example, similar situation, heavily calcified arteries with small size, so they are not good. So it is very important that you should select the ideal access for successful closure of the vessel. So what is important is to puncture at the right place. That is the first important thing. So for puncture also, now what we are doing is we are going by CT scan. We are assessing the calcification at the level of puncture and above. We are assessing for the plaque at that level, high bifurcation if it is there, and location of branches. So it's very important to assess all these things, and not just by the anatomical landmarks which were previously used, like the inguinal crease or inguinal ligaments, because sometimes the bifurcation can be very high or very low. So although this is good for coronary access and coronary intervention, but for large bore accesses, this is not a good idea, because in multiple trials it was shown that generally the bifurcation is below the ligament, but it can be high or low. So most important thing is to assess that where we have to puncture. So most important understanding is to assess where the inferior epigastric artery is going. So this is inferior epigastric artery, which is going around the inguinal ligament. So this is our upper margin, and the bifurcation is lower margin. But definitely we don't want to go below the head of femur. So ideal area for puncture should be in the middle of the head of femur. And how this can be done? What we do routinely, if there is no kidney issue, then generally we puncture contralaterally with a small 5 French sheet, go crossover, and then take a shoot. And on this femoral axis, we puncture in the middle of the artery. So the artery puncture is done with axis, so we can clearly see it in a zoom mode, and puncture is done in the middle part of the artery, so that will not have any problem, because we are going for large bore accesses. So this puncture is very important. Other important technique is, like, if you don't want to go contralaterally, then micropuncture is a very good idea. So this is just an example of micropuncture. You can see that puncture was quite low. This is just a 4 French or even less. So even if the puncture is not at right place, you can remove it, just press for a few seconds, and then you can take another puncture, and this is another puncture taken. And now you can see the puncture is at the middle of the head of femur. So this is also a possible option. And micropuncture is always better because the size is very small. And if you go by size, although it is almost 2/3, but if you go by the blood loss is much, much less. You can see if the larger size normal puncture lead is taken, blood loss is more than 6 times. The other option is ultrasound guided puncture, which is also a very good option. If you are comfortable with it, and then you can reduce complications by significant amount. So either microvascular puncture or ultrasound guided puncture or flow guided puncture. So it has to be a guided puncture. If you're using a guided puncture, then problem is not there. In terms of suture mediated vascular closure, there are 2 devices available. One is ProStar, another is ProGlide. ProStar is mainly for punctures which are more than 10 French, and ProGlide is used even for punctures from 6 French to even 21 French. Only thing is that you have to use it as pre-closed device, and you have to use multiple ProGlide. ProStar is not very common. We have used in 2-3 patients, but it's slightly more complex and takes a longer learning curve. I think ProGlide is most suitable and most commonly used all over the world when it's used as pre-closer. Although there are so many new devices available now, I will not go into details. I will go just on the most commonly used things. So most common thing is you have to be sticking to the common femoral artery, not into the branches. So it's very important. Best is to go by ultrasound guidance or micropuncture. Then use a pre-closed suture-based device. If it is more than 8 to 10 French, you can use 2 devices. Up to 14 French, 2 devices are sufficient. If you're going more than 14, 16 or 18, maybe 3 devices are required. So everything depends on how much size you are using. What we are doing is routinely for 14 French, we are using 2 devices. And if it is not fully closed, a 3rd device can be used. The most important thing is once we are removing it, wire should be kept inside before we are 100% sure that closure is successful, and then it can be removed. And a last DSA check is always a must to confirm that there is no problem. So pre-close, how to use the ProGlide devices, the pre-close is very simple. You go conventionally with the simple puncture first, and once you are coming out, at that point of time, it's very important that through the wire access point, wire should be pushed again, and over that wire you can use a second ProGlide. Generally we use around 40-degree angle or 35-degree angle for between these two nowadays. Previously we were using 90-degree angle. So 2 devices are to be placed in different angles, so that once you close, the sutures are in different alignments, so that will close it properly. So most important thing is once you have done it, you have to check with an angiogram also if there's any kinking or any dissection or any obstruction that has to be relieved. Like in this case, there is some obstruction at the point of puncture site, which was fixed with just a balloon dilatation, and patient was fine with balloon dilatation. So these kind of complications like dissection, like spasm, like obstruction can happen. Once you check it, you know that there is no issue. You can fix it. there can be small bleed which can be stopped with just pressing, or there can be larger bleed which may require surgical access. So most important thing is, if we are deploying with 2 devices and we have deployed the 2 devices after doing the procedure and still there is a bleed, what to do? There are multiple ways. You can use another ProGlide if the bleed is not too torsional. And what other way you can do is you can put a small 6 French or 8 French sheet. If 6 French sheet is closing the leak, then a vascular closure with an angioseal can easily be done. If it is more than 6 French, 8 French, you can try a third ProGlide device that can also close it. If it is more than that, then definitely surgical access, such closure is required, and you should call the surgeon. The one small thing is about in a large vessel access closure, how to use a ProGlide as post closure, not as pre closure. So if the access site is large, what you can do is you can put 2 wires with the help of a bigger size sheet, and then use these 2 wires as access sites for 2 pre-closed devices, and they can possibly close this large access even if you have not used a pre-closure device. So this is how this can be done. This is just to understand that you have to put 2 wires. 2 wires will be at the 2 different places, and they will give it 2 sutures to 2 different parts, and they will stretch the hole so it will not be that big to cause any problem in suture holding. So just to summarize, what to do to decrease complications, access using fluoroscopy or ultrasound. Needle entry should be in the central line and on the femoral head. Femoral angiogram, regardless of
So I have impression we lost our speaker.
Anyway, most of his talk is done, sir. He came to the end of the lecture. One thing interested, what he was telling was without pre-closing, post-closure with 2 wires. Did you try any time like that, Farhan?
Yes, sporadically we do this, but we usually, I personally,
I think I was
in TAVR procedure, I use Manta system, which is very nicely working, but you have to pre-select the patients very nicely. I think if you go with ProGlide, you have the benefit of ProGlide is you have still the wire in position, and if there is still some bleeding, you can go even with additionally with a new ProGlide system, or you can use 8 French angioseal system to stop the bleeding. So this is a benefit of ProGlide.
Dr. Farhan was saying that we can use all these other options for closure, like we can use an extra ProGlide or angioseal if there's a bleed. And there's no hesitation in calling a surgeon if there's a major bleed, because this is a major complication. If it happens, it is a major problem, and we should not hesitate in calling our surgeon friends if you feel that there is a bleeding issue. So I will just come to my conclusion slides.
This is important point. We are really very happy in our heart center, Freiburg Bad Krozingen. In our center in Bad Krozingen, we have a very, very potent, very good angiology department. So we usually ask angiology guys to cover stent, whatever, and then surgery, vascular surgery is practically in background, but usually we use angiological way to
angiologists. We call our vascular surgeons mainly for any problem, and they generally fix it very well. Sometimes they use covered stent, otherwise they fix it surgically. So with this, I want to conclude that vascular closure is a very good option. You can embolize patient very early. Patient satisfaction is much better. There is no scar, so you don't have to worry about scars. So all kind of advanced procedures, we should use this more often. And once you are used to it, you can use it for all these with all the confidence. So I think we should use it more often, even in our angioplasties, so that you will be confident in using these devices, and then you can use it for large access closure also. Thank you.
I think we are seeing in between live cases coming. Before that, we have one last lecture by Dr. Samir Dani, how suture-mediated vessel closure devices change my clinical practice, experience in large hole cases. Dr. Samir, we can restrict for 10 minutes so that we can go on time to live cases. As he's joining, yesterday, other advantage of Manta, what they have shown in the live case, sir, is a single device itself. You can close holes as bigger as 20 French. That was other advantage which is quoted with Manta. Only single device, you can close up the larger French holes also.
It is, that's correct. It is like angiozyl-like device, but not really the same. But we use it practically in TAVR procedures or after impeller use in chip patients.
We can discuss on this closure devices when if the other panel members, I see Raghu, Jabir and others joined. If any comments, otherwise we'll continue the same panel for the live cases too.
So Dr. Farang, if we are using these newer devices like Memo, then is it possible to repuncture the same site, or you have to, if there is some urgency required, then you have to go to other site, or you can repuncture it like we can do in suture mediated devices?
If we go for TAVR or if we go for protected PCI, we usually try to get in upfront angio-CT to understand really how is anatomy in the pelvic region, how is abdominal aorta, how it looks, and then we usually on regarding to this information and to the diameter and how is the plaque distribution, we decide which device we finally take. What I personally do in all TAVR and all femoral accesses, I always use ultrasound puncture. So all my femoral punctures are ultrasound guided, and so that it means practically your complications rate is extremely low. So if you go with ultrasound, this is very beneficial. And then according to the anatomy, then you decide where to perfectly make a puncture, in which angle, and then you can also decide after ultrasound check, you can decide either you take Manta system or you take ProGlide. And what we have practically always contralateral injection, as Dr. Nagendra perfectly showed, then to check in DSA technique how the puncture site looks. So the patient should leave cath lab with really safe, 100% safe growing puncture site. This is very important to avoid later on very dangerous complications.
There are no further comments in this.
Then just one small question. Yeah. Okay.
Yeah. Go ahead.
So one small question is regarding. So if you use this glue-based devices like Mementa or AngioSeal, can you repuncture the same site? How much time is required before you can repuncture the same vessel if required?
Yeah, normally you have to wait, and normally you have to wait around 10 weeks between to go in next procedure to use this puncture site. What you can do if there is emergency case next day, you can again go with ultrasound puncture, go 1 centimeter, 10 millimeters up or down, and then you can, from my perspective, also make a safe puncture if there is no option to use another groin.
Other side.
Okay, thank you.